there have been some amazing topics and amazing presentations today, which has been absolutely wonderful. And I want to say a huge thank you to everyone that has participated and presented today, which has been, I think, a very informative day today, which is fantastic. Now, feel free to add your questions and comments. We have, as I mentioned before, we've started to get a really good list of questions coming through. I think I've got, I hope our panelists are ready for what you guys have been asking, because we've got a really good list. Sorry, pardon me. And I suppose it's now time to introduce our amazing panelists that are here for the Q&A. So you saw Phil present earlier with regards to the treatment guidelines and the new Australian New Zealand treatment guidelines, our first for us specifically, and how they were, but the methodology behind them and what they mean, I suppose, for ITP patients and treating clinicians here in Australia and New Zealand. And our other panelist who's joining us today is Dr. Danny Su. Now, Danny is a consulting clinician at Liverpool Hospital. And some of you probably know Danny quite well. Both of these guys are amazing clinicians, have an amazing bedside manner, great sense of humour, which is always wonderful. And they are extremely patient-centric. They really ensure that the patient is at the centre of all of the decisions that they make. So I'm really looking forward to picking their brain a little bit with some of these questions. Now, both of these guys were also in the working group when it came to developing the new treatment guidelines. So we've got we've got the top end of the scale here for our panelists. I can see them grinning along. So let's get on with starting our Q&A session. So what we might do is we might get the guys to unmute themselves.
Thanks, Danny and Danielle.
double Danny and Phil. Is that? I don't know. It's all good. Okay, guys. So as I mentioned, we do have quite a lot of quite a few really good and a couple of tricky questions in there. But I might actually start with a fairly easy one. A lot of patients have noticed, especially across social media and that sort of stuff, that there have been a number of, there've been a lot more patients and ITP patients over the last couple of years. Is there any data to support that information, or is it just obviously with the prevalence of social media and the digital age that we're just noticing it more?
I suspect it's probably is the social media platforms are really, probably the first times connecting patients, together. We never really had a medium by which, it was that easy, I think, for patients to connect with each other. And of course, it's thanks to organisations such as ITP Australia, Danielle, that really is able to bring people together and raise the awareness that there is patient support groups, that patients are certainly not alone, out there. I think it's had a huge impact, I think, in terms of increasing awareness, of this condition. I'm interested what Phil thoughts are.
Yeah, look, I think there's a few things. Firstly, there's always been seasonal variation in the prevalence of ITP. So a lot of reporters, particularly from France, have noticed that there's a lot more ITP being diagnosed, I think, around springtime than there is at other times of year. So there are fluctuations, but I think, I mean, you can't not mention the elephant in the room, like COVID, and that's made everything from platelets to having to see a doctor or doing blood tests or checking to see if you're bleeding or clotting so much more part of daily conversations around office tea rooms and with your GP and so on. I bet politicians out there had never even knew what thrombocytopenia was or what platelets did or anything like that. But there was a time last year when everyone was talking about this clotting disorder with low platelets and this and that. So there's a lot of awareness, obviously more bad than good, but we'll take the fact that more people are connected.
I have to admit too, we did see a lot more traffic across the website as well during that same period, Phil. I had loads of questions going, oh my God, like, so this thrombocytopenia, tell me more about it. So there were a lot more conversations out there as well, just from the general public. It wasn't clinicians, it wasn't just patients, it was, people I'd come across on a daily and a regular basis as well. So, the awareness has definitely increased, and hopefully for the better, while it wasn't technically for a good reason, but I think that the awareness has definitely increased, which is good. So cross fingers, which is good. Okay, so I'm going to touch on a little bit. We've got a couple of questions with regards to ITP and ITP symptoms. First one is fatigue. We just saw there in the IWISH study that fatigue is definitely, from a patient's perspective, actually quite debilitating, and is definitely, a factor with their ITP. Do you guys see much fatigue and talk much fatigue, and do you have any recommendations, I suppose, for patients when it comes to the fatigue?
Danny, do you want to start this?
Sure. I mean, no, it's I think Drew had sort of very beautifully presented. I think that's one of the subjective symptoms that as clinicians for a very long time that we really didn't quite realise. I mean, how prevalent, I guess, symptoms of fatigue was, and I guess the underlying cause of it, I think, is still a little bit unknown. And I guess I think about it that there's potentially really two, I guess, main etiologies. One is obviously treatment and related, and one is disease related. So the treatment related aspects, of course, in patients, and I'm sure a lot of you out there who've been exposed to steroids, not very conducive for a good night's sleep. And really, that's an understatement of the century, I think. So really, I mean, some of our treatments might impact, of course, quality or sleep, and that will contribute somewhat to, of course, to feeling tired and loss of energy. But we do know there's certain hypotheses that the disease itself, could be that when patients have low platelets, and this is interesting, isn't it? And I'm sure Phil has seen this as well, where patients, when the platelets drop, they do feel that sort of really washed out, exhausted sort of sensation. And one of the theories is that it could be that due to increased platelet production of the cytokines that increase, these cytokines kind of mimic, I guess, the same cytokines that are released during sort of acute infections or illnesses. So that's sort of one potential explanation for fatigue. But no, I certainly see it a lot in our patients, and certainly a symptom I often ask about. Now, in terms of how to address that, I think it is difficult. I mean, I think, as I said, that you've really got to dig a little bit in terms of, is this fatigue the contributing from the treatment, and also, of course, potentially female patients. What I think about is there's more menstrual bleeding. Are they iron deficient? So we've really got to think a little bit outside the square to think, is it what can contribute to that? But I think it's often multifactorial, and I'll be interested in what Phil's thoughts are.
Beautifully put, Danny. I think anxiety and just the fatigue of constantly worrying about, well, what's next week's platelet count going to be? What's my next treatment going to look like? A lot of the uncertainty around the diagnosis often drags on into treatment aspects. So when you're weaning your prednisone, what if my platelet counts crash? What am I going to get next? Rituximab side effects, this and that. So there's a constant churn of something in the back of your mind about, well, what's going to happen next to me, because my doctor can't predict it. And that's the sad reality of ITP at the moment. Biologically, there's also this concept of platelets carrying little packets of neurotransmitters called serotonin. And some people who are on tablets for depression might know they're on a medication called a selective serotonin reuptake inhibitor. So there are some people who speculate that in particular, the low platelet counts have an effect on your mood because of there's just less serotonin in your body that survived, and so you're more vulnerable, I think, to changes in mood. So there are lots of really important reasons to have that conversation with your doctor or your family or your friends when you're not feeling well, or when you're feeling tired, or needing how great is it to have a sympathetic boss who can help you be more flexible with your hours, for example, on days that you're feeling really fatigued.
I think personally, as an ITP patient, I have acquainted myself with Netflix when it comes to fatigue. My Netflix subscription, gets a good workout. But I think, and this is maybe mainly more from a female perspective, but as a mum, as a woman, sometimes we're told to just charge through it and keep going. And it took me a number of years just to, give myself permission to lay down, stop. And it took me a long time to do that. And I actually, when I changed from my corporate world into my own business, gave me a lot more flexibility, which was fantastic. But there was many days that I would just be absolutely exhausted, and I was so drained. And a little tidbit: my husband's actually been donating platelets for the last 24 months. He comes back from a double or a triple platelet donation and is exhausted. So it's quite. I sort of say, okay, yeah, whatever, go and watch Netflix, off you go. But he's actually quite exhausted after that actual donation, whether it's obviously taken a lot out of him, or whether it's related to the platelet count, or whatever. But it was quite interesting to watch that on a regular basis. He'd come back from his platelet donation, and then all of a sudden he was actually quite tired. So it's an interesting thing, and it's something that I think impacts. I think we need to learn to give ourselves permission to stop, which is the big thing, and that it is okay to be able to do that. Now, keeping on symptoms, we had one question from a patient where obviously fatigue is a big issue for her, but she also has some joint and muscle aches and pains, and she doesn't want to sound like she's sort of complaining, but what's the best way to convey those types of symptoms to her clinician, and how would to best describe them, I suppose, to encourage whether it's a change in treatment, or even just acknowledging that these things are happening?
But some of these symptoms that sort of come and go, it's good to have a diary, I find. And I tell patients, look, see if you can try to jot it down, whether it be on your iPhone or on a piece of paper or your journal, so that particularly if it's something to do with treatment and there's a change in treatment, you can go back in your diary and go, definitely this month has been a lot worse, or compared to 3 months ago when I wasn't getting it more than once a week. And then one thing that always helps your doctor stand up and take notice is to get it in terms of severity, to get a sense of how much those muscle aches interfere with work. Like, did you have to miss a day of work because your legs were so aching you couldn't, walk properly, or if it interfered with your sleep? Those sort of things really make us prompt us into action. Whereas when you just say, oh, look, it was, a bit achy or sore, then it becomes a bit harder for us to understand how severe it is. But definitely things like iron deficiency, like Danny pointed out, particularly a lot of our ITP patients out there, if you're younger, if you're female, if you're menstruating, if you're not into eating a steak every Friday, iron deficiency is a pretty common thing that we see. And it's often it flies under the radar because we're all focused on your platelet count.
That's right.
But it's definitely treatable.
Wonderful. I know personally I've got an iron deficiency. I actually go and have an iron infusion every couple of years to help with that because there are obviously absorption issues, and with the oral iron supplements may interact with different treatments as well. So
yeah, an oral level trombopag.
Yeah,
Definitely. Yeah.
yeah, found that one out the hard way, unfortunately. Which was good. Now, sticking with symptoms and not necessarily physical symptoms, stress do you find that stress, possibly going back to the diary, that stress can impact platelet count and I suppose the symptoms that come with ITP?
Now, I must say, I'm not aware, I guess, of any actual association between stress at all with, with platelet counts. I mean, really, the way to think about it, I guess, our bone marrow factory is a pretty essential function. It's really very well insulated against everything else that's going on in our body. That's the way I try to explain to my patients. So it's very minimal things that happen day to day that could impact, I guess, production of platelets, and certainly in this disease state. I think there's no linkage. But really, I think Drew, when you discussed this, the president of the Irish study, the rates of depression and anxiety in our patients with ITP is not insignificant. And throwing in on top of all that, where you're living with a chronic illness, and then you've got these, drugs like particularly steroids that really, for a lot of people, could, trigger feelings of anxiety just from a drug effect. Really, set ourselves up for a scenario where a lot of patients absolutely would experience, I guess, some form of stress anxiety for other disease course. But really, I don't think it actually exacerbates or triggers, I guess, relapses. And I do think it's important to tell your clinician about. And I know a lot of patients probably, don't talk to their clinicians about that. They might not feel, or they might feel it's not linked at all with their ITP, or they just feel uncomfortable saying that, I'm really, worrying and obsessing about my platelet counts all the time. Not. It depends, I guess, that therapeutic relationship you have. But we, as a doctors, we're here to listen. We want to hear that you're struggling, that you need potentially, psychological support, and maybe just talking about it. Because I think that what really struck me, for example, in the Irish study, was that fear of death in about 40% of patients. Mm-hmm. Which is extraordinarily high proportion when, myself and Phil, we would very rarely see anyone die from ITP. And we know this, like it's almost a given to us, but it kind of concerns me that patients are not telling us. So there's 40% of patients out there who are thinking they might die from ITP when, we could just say, hey, it's actually something exceedingly rare and then something happened to you. So just, I think, communicating openly, I think, with your clinician, works both ways. We all know what you're worried about, and if you could help, really reassure, I guess, some of the concerns that patients might have.
With stress, I maybe I'm a bit more of a dreamer, and I recollect anecdotes, and sometimes dangerously I retell them. But I remember an elderly patient I had who was previously absolutely well, but I had to call her as she was burying her husband, that, look, your random platelet count is suddenly 12. You'd never before had a low platelet count. I'm giving you a diagnosis of ITP. I'm sorry to disturb you. And she was, of course, extremely stressed with the sudden passing of her partner of many, many, many years. And over the course of maybe 6 to 8 weeks of having blood tests every week, her platelet counts gradually got back to normal without any treatment. So that's an anecdote, which is dangerous, but I do think that for some people, extreme emotional disruption has strange effects on your hormone levels, on your catecholamines, on all sorts of things. I mean, we all know that when we burn the candle at both ends and we work too hard, we sometimes become more susceptible to a viral infection or an illness. Maybe there's some kind of indirect link that way, but definitely I have seen people who've had a rough time, and then on top of it, life throws them ITP. So yeah, I mean, if any of you out there have had that kind of experience, you're not crazy, you're not having a unique experience. I think it happens.
Yeah, I think you're right. It really depends on the individual as well. I know that personally, when I'm again burning the candle at both ends, I'm not necessarily looking after myself. So therefore, I'm probably not taking my treatment effectively, which then sort of starts that snowball effect. So it's all, you know, it's like a scale, and weights. If you're not doing one thing, you tend to start to the scales tend to weight, and that's my personal experience. Not saying that's the same for absolutely everyone, but I know that, you know, if you're looking after yourself and you're focusing on myself, and it comes back to mental health as well, not just my physical health, you know, when one's not aligned, the other one generally isn't either. So yeah. With regards to Phil, you mentioned in your presentation, you touched on COVID a little bit, and we'll do the talk about the dreaded COVID just for a little bit. You mentioned the TGA, the current TGA findings with regards to the vaccine. How does the TGA, how do you guys as leading clinicians identify that ITP has been caused by the vaccine, as opposed to you know, someone like me that it wasn't vaccine related?
I think there are two parts to this. So there's patients who never ever before had ITP, and suddenly they've just got a new diagnosis of ITP several weeks after a vaccine. And then the other part of the question is those people like yourself, Danielle, or someone else with a long history of ITP getting a vaccine and then suddenly relapsing. So talking about the first group of people who never before had ITP, absolutely, we have no way of knowing whether it was just sheer coincidence or not, that the ITP just happened, because ITP happens. People get diagnosed from time to time. And we know that people who have viral illnesses or a cough, cold, sneeze, flu, sometimes then get ITP. That was always the case. And whether the vaccine mimicked that sort of viral infection in the body and brought out a vulnerability or susceptibility to get ITP, we don't know. But that comes back to the forever uncertainty of the diagnosis of ITP. We are always challenged to come up with our gut instinct feeling about what's going on over the phone. And over time, we often end up modifying our diagnosis and go, oh, it was the antibiotics all along, or too many gin and tonics, or, oh, actually, this really is ITP. And look, in reality, all this COVID vaccination stuff, it's still very fresh and raw, and it might be that in the next 6 to 12 months, I'll be singing a different tune. In terms of the second group of people who already have a history of ITP, what we know from our local data set in Australia is that of the cases that we've looked at, clearly there are a lot of ITP people who had very, very stable disease, no dose adjustments, platelet counts beautiful for a long time. They get vaccinated, and then boom, it just feels like too much of a coincidence. And I think there's a strong sense that the vaccinations rocked the boat, but that's really all it is. It's rocking the boat. It's not necessarily capsizing it. It's not tipping it over. And lots of things have always rocked the boat for you guys with ITP, whether it be stress or some other infection, surgery, hip replacement, diagnosis of breast cancer. Lots of things happen in life, and lots of things rock the boat. And I think maybe vaccination just rocks the boat a bit. But that the safety you get from not having overwhelming COVID engulfing your lungs compared to the risk of rocking the boat and needing some extra intragam or needing a couple of weeks of steroids or maybe a higher dose of your end plate. I've always tried very hard to get every one of my patients vaccinated.
Have either of you experienced any ITP patients that have developed COVID that have been, obviously have been vaccinated or not vaccinated?
Yes. So working in Liverpool, yes. So for a while, as some of you might know, I guess southwestern Sydney was probably the epicenter of COVID cases, and look, like as would happen, I guess, with any viral infection or any acute infection, yes, the platelets did drop in the patients. Similar to really any other sort of exacerbation that we see that's related to infection. So there was nothing sort of special about it or worse or catastrophic about it. So this particular patient of mine was on a TPO-RA and just meant that we had to add steroids really for a little while to just tide him over. And I think really described it very quite well. It is just rocking the boat, and once the sort of waves go past, the patient stabilized. So I think going back to the vaccination thing, that similarly, we see exactly the same thing. So it's actually very, very rare that I guess you need to completely change one's ITP management. These are patients who've got chronic ITP, get the vaccine, there's a drop. It's actually very uncommon that it's change the treatment sort of forever from that little sort of mild exacerbation. And so I had a lot of patients who had the Pfizer vaccine, and I warned them that there's a chance it could dip down. And all my patients on TPO-RAs, it's interesting. I think my field actually have picked up that there's a trend that patients with TPO-RAs tend to have more fluctuation in their platelet count. Those are the ones that I've been seeing where the platelets do drop a little bit, but they're generally about half. And just put a little bit of steroids of 15 milligrams or so for a week or two, and just sort of then ties them over. Every about after 2 weeks, it goes back to their baseline. So I guess, yes, initially, where we didn't have that experience, we're pretty sure what's going to happen. But then I think now, having had a number of patients who went through that, a bit more comfortable that, it's just, it's sort of something that's temporary. You've got to just ride it through. And then generally, they don't need a change in the treatment.
COVID's a bit like a jet ski as it whizzes past.
Exactly right. Yes, exactly right. Yeah.
Bloody jet skis, I tell you. I'm going to touch a little bit on things like clinical trials. I know that's obviously David was talking earlier with regards to a number of treatments that are coming through the pipeline, but he also touched on clinical trials and access to clinical trials here in Australia. Now, there are obviously a couple of clinical trials happening. If there's a patient that doesn't necessarily work with a haematologist like either of you, what's the best way for them to try and reach out, or do they reach out just to the general clinician to put their hand up and say, I want to be considered for this clinical trial? Like, what's the best process for those patients?
I think it might depend on where you live. And so in Canberra, I guess we serve a large section of Southeast New South Wales as well. So there's a lot of long distance travel and referrals and all that takes place. If you live in a big metropolitan centre, that's often a lot easier for accessing clinical trials. A lot of the time there are competing clinical trials. And so there'll be a hospital where, like us, where for second line ITP, we'll only have one trial running at a time rather than 2 or 3, so that we don't compete too much. And so depending on what sort of medication you might be preferring, you might need to travel in order to get something different. Definitely have that conversation with your treating hematologist. And sometimes if they're not aware of a trial, just gently say, hey, I've heard about such and such. Do you think you could inquire about it for me? And most hematologists will go, oh, sure, if I haven't heard of it, I'll look it up and I'll find out who's running it. It might involve travel. And trials often involve a lot of time, a lot of extra testing, a lot of waiting around. I think clinical trials are really important, but Danny, I mean, my feeling is they're quite artificial as well. The screening period, for example, for someone to get onto a clinical trial means that you sort of have to be well enough for at least 4 weeks on nothing else before you can get onto, you know, the medication. If you were that well, you don't need a clinical trial often. So it's only people who are very stable with low platelet counts that get onto trials. There'd be a lot of people in the audience who have a kind of ITP where for years their platelet counts are fantastic, and then suddenly, boom, they crash. There's no clinical trial that's ever gonna, or that's currently running to help those sort of ITP cases. We've got lots of trials that help people who have just an always lowish platelet count. But definitely have that conversation with your hematologist. I probably, wouldn't go around their back, mostly because you also need a lot of that data, or a lot of that information about what treatments you've had, what platelet counts have been like, all that sort of stuff. And there's a lot of history there that you need to carry with you.
And I just want to add, I think as a community, hematologists we are a pretty friendly bunch. So really, you're treating hematologists. I think we absolutely have zero, issues with reaching out to Phil, Robert Bird, or myself, and I certainly get emails and texts, asking for advice, and I'll just say, well, where are you? Okay, go find Dr. Bill Choi or Rob, or wherever they are, might be in the country. So look, there is no, don't feel. It's not awkward at all. I think, think about it in oncology, everyone seeks a second and third opinion, right? And hematologists are way more friendly than oncologists. So, your treating doctor will have no issues, I'm sure, reaching out to one of us who might have a clinical trial in our centres.
One of the things that we do get a lot of questions about getting a second opinion, and I really don't want to upset my doctor. So it's not about, I suppose, upsetting your doctor, because this is your health, and if you want a second opinion, you're entitled to a second opinion. If I was to get a question from a patient about referring, say, either of you to, and I have referred both of you in the past for that second opinion, other than giving names, should these patients be getting a letter from their current treating clinician as a recommendation to come and see you? Or what's I suppose you're in your areas and with your in say in the ACT in New South Wales, is that required, or can these guys just ring up and say, hey, I want an appointment with Danny or Phil?
You will, in order to be able to be bulk billed or be able to attract a Medicare rebate, you'll need a referral of some sort, whether it's from your GP, it can be from your current treating hematologist, but usually the hematologist that you have, or the doctor that's treating your ITP, will have the most background information about you to be able to help us provide that second opinion without having to reinvent the wheel and repeat tests that aren't needed, and give you treatments that you've already had that didn't work. I think it's always safest to go that way.
Yeah, I completely agree with Phil. I mean, there's certainly some nuances, I think, that we really don't expect, I guess, general practitioners to be aware of. When we're really coming from the treating physician, might be looking after patients for a long time. We really want that really more, I guess, in a comprehensive history if we can. And we'll just really make it more efficient. Essentially, as Phil says, we don't have to then go through the sort of 5 to 10 years history of every treatment the patient has had.
Wonderful. When it comes to, I'm going to sort of change this a little bit. There are a couple of questions with regards to genetics and genetic links with ITP and genetic testing when it comes to ITP. I'm not a clinician. Is it a thing? Is it something that you guys test at all? Or is it something that's sort of a future possibility maybe down the track?
Yeah, so most of the genetic testing that people do in the context of ITP is to look for evidence of something that isn't ITP. It's to look for this thing, a whole cluster of diseases or disorders that people can be born with that might impair the way your body makes platelets. There's a whole bunch of them that we can diagnose with genetic testing. But often a family history will give us the strongest clue that it's worth pursuing. People with the most difficult ITP with platelet counts less than 10 or less than 20, they're very unlikely to have one of those, we call them congenital or inherited thrombocytopenias. In terms of genetic testing for ITP, that's certainly in the research realm. I know that in the States, Jenny Despodovich and a couple of others in the pediatric space are a lot more into looking for that. And I guess with kids, you have a sense that they've had less exposure to different environmental stimuli because they're so much younger, that maybe genetics play a more important role in them getting ITP. Whereas as adults, if you get ITP in your 30s, you've done whatever damage to yourself in your teens and your 20s, and you've exposed yourself to various viruses and infections, there's a lot of different things at play. So there's a lot of noise in terms of the genetic susceptibility. It'd be great to have a test one day that we could do to say, yep, this is ITP or it isn't. Maybe genetics will be part of that. I don't know yet.
Did you want to add anything, Danny, or are you happy with Phil?
No, I mean, yeah, I think genetics will be, will certainly be very interesting. It's so tricky, isn't it? I mean, you would assume that the signals we'd see might be in how everyone's immune system functions, and the immune system's got so many multiple arms that I think it requires a lot more research. But certainly it would be a fascinating, I think, potential future.
If there's anyone with Evans syndrome out there, there's a CTLA4 gene mutation that's been sort of worked up recently. So like there are little pockets here and there where it's creeping in, but for just plain vanilla ITP, it's so many differences.
Yeah. We did get a question from one patient wanting to know what are the chances of getting ITP or a child getting ITP from their mother, considering is it the possibility of it being hereditary? Is it just coincidental?
So there are two parts to that. Obviously, little babies that are just born, sometimes their platelet counts are a little bit low because of the antibodies that have crossed over through the placenta, and so they just have a very a brief excursion in ITP for a few days or weeks, but yeah, coming back to that whole genetics, we feel that sometimes there are families where there's a genetic susceptibility to autoimmune diseases. So you'll see families where people have, mum's had a thyroid problem, dad's had maternal aunts had rheumatoid arthritis, a sister's had lupus, and now you've got ITP. And so we see that, but I would never ping it on just my mum or just my dad. Maybe with behavioural traits, but not with ITP.
Yeah, we've been known to become collectors. I think once you get one autoimmune disease, it tends to start to collect a few others down the track the older you get.
Yeah.
Yeah.
Moving away from the genetics and that sort of stuff, and talking specifically about L-trombopag and the TPORAs, I know, and from experience with a lot of patients, how hard it is to get access to the TPRAs pre-splenectomy. Any recommendations for patients to talk when talking to clinicians who you know don't necessarily want to go down the splenectomy path to get access to TPRAs?
Yeah, I think that has been, you know, probably the most common sort of asked sort of question for us, and I think it's tricky, isn't it? I think for clinicians such as Phil and myself, who are, you know, probably more familiar with prescribing these drugs, we probably have a lower threshold in terms of applying, if I might speak on Phil's behalf, and really, you know, in our experience, that sort of requirement for a splenectomy is not as absolute as a lot of other sort of general hematologists think. And really, I've could honestly say I don't think I've ever had an application ever rejected for a TPRA in a non-splenectomized patient. And I guess I've got to be careful what I say, but you know, but I think that, especially with all international guidelines coming out, and really, you know, Phil's very own Australian New Zealand guidelines, it's quite clear now that, you know, really, you know, TPRA is right up there, the second-line therapy for splenectomy and rituximab. And if you look outside our shores, I mean, really, they're very widely used in Europe and you know, North America. So really, I think that, you know, I just want to tell a lot of general hematologists out there that I think that it's not as hard as one thinks to access TPRAs for our patients, and, you know, the right clinical context. And yeah, I have no qualms in a non-splenectomized patient to apply for it. And look, there are probably certain tricks into how you word that cover letter during the application. But yeah, I think it's really not as big a barrier, I think, as it previously was, I think, when the drugs first came out.
I think too, one thing that, you know, we need to remember too is that splenectomy can work as well. So, you know, while it is, you know, will it work, will it not work? You know, that conversation is there, and it is surgery. You know, for a lot of patients, it does actually work and does put them into remission without having to, you know, do daily treatments. And some people want, you know, would prefer to go the splenectomy to, okay, then I'm fine, so I can sort of get on with my life type scenario as well. So it's not everybody. And I know, like you touched on there, Danny and Phil, during your presentation, things like the, you know, it is now considered second, you know, through the treatment guidelines, the second line treatment, TPRAs and splenectomy. And it's one of the things, I suppose, that we are, ITP Australia is really heavily focused on through the federal parliamentary inquiry, you know, just putting it to the politicians, you know, that, you know, you're asking somebody to have their spleen removed because it's cost effective for you now, not necessarily, and they don't necessarily look at the long-term economics behind, you know, splenectomy comparative to the TPRAs. But the cost of TPRAs are also coming down as well, which is fantastic.
And there are different TPRAs coming along as well. So avatrombopag, with any luck, will be in Australia soon.
And I think, to me, probably the main focus, and I think, you know, our guidelines reflect this, and sort of Drew's international consensus reports the same. I think treatment options really should be patient focused, because, I mean, as you said, Daniel, I mean, I certainly have patients where they said, is there one treatment I could have where I don't have to take a tablet or injection ever again? And absolutely, I have young patients say, you know what, yeah, look, I'm willing to, you know, in a way, gamble and do the splenectomy, because there's a 60-70% chance that, you know, I'm going to be never going to have a, you know, low count again. And some will much prefer that. So, you know, I think to me, the main thing is, I don't want, I guess, you know, I don't want clinicians out there to think that it's very, very difficult to get TPRA and it's going to spleen out. Really, these treatments are now on, I think, should be offered equally to our patients, and it becomes a, you know, I think it has to be a really, you know, frank discussion with clinician and patients and what's appropriate for them in their lifestyles.
Always comes back to the quality of life, doesn't it, and the patient journey. They're the ones that have to live with this, right?
Exactly right. Exactly right.
Yeah. Okay, last question, guys. And thank you to everybody for submitting all of their questions over the last couple of hours. It's been absolutely amazing and fascinating to watch. Now, we've published the treatment the new Australian New Zealand treatment guidelines. I know that we promote them on our website and we send links far and wide to patients, etc. But within the hematologist community, what are you guys doing to promote these treatment guidelines amongst yourselves and amongst your peers?
I'm going to handball that to Phil, the boss.
I mean, we're a group, we're a team. We have had lots of meetings around the country, sort of publicising the guidelines. To a large extent, being the first iteration or the first edition, there's no radical departure from what most hematologists around the country are currently doing. But by putting it out there, it provides us that foundation to build from, particularly over the next few years. As you know, if you're listening to Dave Kuda's talk, so many new drugs around the corner. We haven't had an explosion of new therapies like this in ITP since, you know, Nplate and Revelade were first being trialed. And how many years ago was that? So
that's a long time.
Yeah. So we're on the precipice of like a big change, I think, in our treatments. And I think Robert Bird really needs to take a lot of credit for this, because it was his idea to sort of get this off the ground. And because now that we've got this foundation, now we can build from it and try to do it in a way that's logical and everyone can follow what's going on and sequential. So yeah, lots to look forward to, particularly if you're someone with ITP where things aren't perfect. But yeah, definitely in terms of the guidelines, not a lot of new information in there for most practicing hematologists.
And one of the big things is we've encouraged patients to print them out, take them with them to their next appointment. I've given a copy to my GP. I share them far and wide, and I encourage patients to also share them far and wide. ITP patients are highly educated, and they know so much more about their disease compared to their GP. So they're the ones that it's also really important that as a patient and as patients that we band together to broadcast and communicate. And as you said, Phil, this is the first iteration. Like, we are only going to go higher and far and wide with updates and with regards to these guidelines, that they will change. It won't be the same. They will continue to change, as these new treatments come through. But I think if we can all work together to build the awareness that these are the guidelines, and for Australia and New Zealand specifically, because we have been working off the international consensus guidelines previously. So I think that as a working group, you guys have done an absolutely amazing job. Yes, Rob, to get that off the ground was amazing. Thanks so much, Rob, for all the hard work and the hard work of all of you for developing those guidelines, so patients have a bit of a cheat sheet, I suppose, as to give to their clinicians, but also have for themselves as well, to educate them a little bit as well too, which is fantastic.
Maybe I'll just say that I know Rob's our spiritual leader in the development of these guidelines, but really feel
yes,
hours he's put into this. We have to thank him as our leader in putting this all together. And I remember emails at midnight also, we're still calling for the manuscript. It's various reiterations. So Phil, thank you really for your hard work on this, for bringing us all together. And I think it's fantastic. It's out there, and really. I think our patients would really benefit from it, but really want to hats off to Phil for all his hard work.
Definitely talking about burning the candles at both ends there, Phil.
Absolutely.
Thanks, Danny. I mean, It was a group effort.
Humble as always. Humble as always. Thank you so much, guys. Really appreciate it. Thank you so much for spending the time to chat with us and to answer all of our patient questions. I know there was a few. Yes, Phil.
Danny, I'm just punching answers to some of these questions that have come up in the Q&A.
Yeah.
If people, I don't know if they can wait, I'll work through them all. I'm like halfway through, so.
Oh, yeah. Wonderful. The other thing too is that if any questions don't get answered, feel free to hit us up at in the contact us section of itpaustralia.org.au. Hit us up on the socials as well, on Facebook and Instagram and Messenger and all of the different platforms that you all use, and email as well, info@itpaustralia.org.au. It's very rarely that I miss an email, even at midnight. So it's something that we try and respond to quite quickly as well for patients, because we know that some of them are time sensitive, but we want to make sure that we speak to all of you and give you all the information, all the answers that you guys are after as well. So thank you so much. Now, Phil is, look at him typing away. So diligent, so amazingly diligent. I love it. Love it so much. The passion and this is what you get from these guys. What you see is what you get from whether they're consulting with a patient or working hard on a Saturday afternoon, answering questions and listening to my jabbering and answering my questions as well. So I really appreciate the time and the effort for everybody for making today a success. Over, I think the final tally was 210 participants across 23 different countries. So thank you so much to everyone for registering. I hope that you learnt a little bit across all of the presentations as well. And thank you so much to Phil and Danny for letting us take up and chew up some of your weekend. And I hope that you both enjoy the rest of the weekend and get to put your feet up even just a little bit, because you deserve it. You both. You all deserve it. You all deserve a bit of time out, especially over the last couple of months and years. So thank you so much. Wonderful. So that's all from us from ITP Australia and the ITP conference. If you do have any questions that Phil is answering, feel free to stay on. But that's us for now. Thank you so much. See you guys soon.